troubleshooting is really, it's two-pronged. It's what you observe and then the communication with that. To me, it's obviously reading, looking at the floor scene and looking under the slit lamp, and that observation and what you see is probably the biggest part of it. But then that communication has to come along also, and not just the communication with the patient, but also if you are using consultants, that communication between you and the consultant is very important. And if you can take that observation and that communication and connect them, then it really makes you more successful. And obviously the success can revolve around, less chair time, less returns, exchanges with lenses. So as consultants and as fitters at X-Cel, we really try to communicate very well. We go through a series of questions, or we try to go through a series of questions to help with that communication. And we try to ask the same questions to get the best information we can, because we are not sitting in front of that patient. We don't always get pictures, we don't always get videos or topographies or anything of that nature that would help with the fitting process. So we've got to ask the right questions. And I'll just give you an example. We always start in scleral lenses with, how much central clearance do you have, doctor? And then we can work our way down. So we need to know that first, and then we go down a series of questions. The second question is probably going to be, well, how long has the patient had the lens on? Because that's important to how much clearance you have. And then from there is, how are you measuring that clearance? Is it through a slit lamp? Is it through an OCT? So we ask these series of questions, and I think it's a good idea as a practitioner to probably form some questions around, your fitting process to ask the patient, because this helps you. Troubleshooting is coming after the fact. It's after something has happened in the fit, and now we need to solve that problem. But there's so much we can do in the front end to take care of those problems if we are communicating properly, and if we are observing something and making the right decisions as we go along. So it's something to think about on both ends, the patient communication and then that communication to the consultant, or when you're ordering the lenses. It's important to know the design of the lens. You should know what you're doing with the lens and what design it is, because they're going to act differently. So, as we go through those questions with patients, you'll start to form this pattern with them, and whatever the questions may be and the answers that you get, that's how you can make your decision tree or your next step with the fitting process. So let's just start at the high level and think about scleral lenses and materials, because one of the things I love about scleral lenses is we no longer utilize lower decay or even mid decay materials. So we're always using high decay materials when we're fitting scleral lenses. And I'm not really sure why we haven't gone to this earlier. I know there's a need for some of the mid-K materials and the lower decay materials. Most of that need comes from stability of a lens. So the lower the decay, the more stable the lens is going to be. It used to be that once we increase the decay level of the lens, all right, that would deteriorate that lens, meaning they're more susceptible to warping, more susceptible to scratches. It wasn't as durable as the decay went higher. But now the vendors and the material people have done such a great job at developing newer materials that are higher decay, that are durable. This really eliminated the need for a lower or mid decay. And again, I'll go back. That's the great thing about scleral lenses. You really don't have an option of anything less than 100 decay, which is really nice, because there are so many studies coming out and we're getting more and more information on the effects of the thickness of the lens and then the tear layer, which is how much clearance you've got once that lens is settled, right? All the saline and tear. So we've got to go through the lens, now the saline and tear, and actually what kind of oxygen are we getting to that cornea? We also know with sclerals, we're not getting much tear exchange, right? We're not getting much tear exchange, if any, and That's another way we can get oxygen to the cornea is through that tear. It's probably the best way. So we've got to think about that level. And if we are seeing problems with that patient, all right, hypoxia-related edema, right? We're not getting that oxygen through there and through that. Can you please mute your phone or computer, please? So if we're not getting that and we are in a decay lens of 100, well, we've got to go to a hyper decay. So important to know when you have a fit set, what is that lens material? And then if you need to make a change, what am I changing that lens to and what material should I move to? And again, the consultants can help with that. So we have those 100 DKs. We have Boston XO and HDS 100 and Conemax Extra. And then we go up to the hyper DKs where we can go up to an XO2 or the extreme in the Conemax materials. So something to think about on the front end. Know what you have in your set or what you're ordering with the lab. A lot of times at the lab, if we don't get a material preference from the practitioner, we'll start them out in that 100 DK material and then work from there. Once you do go up to that hyper DK, so an XO2 or an extreme, you do lose a little bit of that durability. So it can go back to the patient. And a lot of what we're going to do in this troubleshooting is how you have to know what you're dealing with the patients. Do watch them going through the cleaning regimen, watch them handling the lens can also help with choosing a material or troubleshooting some other problems. As we look at this and we talk about the patient and how they handle the lens and the insertion and removal process, I always go back to, it's great. We can teach them everything we can in the office. We have great resources online that they can use. But once they leave that office, what control do we have over that patient? So knowing that they are applying and removing that lens properly is very, very important. So it's repetition, repetition, repetition. It also is giving them the resources that they need. What resources can you provide them to give them the best ability to comply? So not only is that compliance with the application removal technique, but it's also solutions and cleaning and proper care. So what can you give them on the front end to make sure that their compliance is lasting as long as you possibly can? And a lot of practitioners, you can see examples here, will give them a cleaning regimen, a care systems that start out, the insertion and removal tools. They'll give them the unpreserved saline to start them off, be it a 3-month supply or a year supply. They'll also go through the care system, the cleaning regimen in a form of hard copy to give to that patient. So they always have that. It's one thing to give them a resource and say, go on this website and you can see it. And it's another thing to actually have that with them. And what we've developed is a nice little care kit that the patient can have where we can fit in the DMVs, a lens case. It has a mirror and you can fit unpreserved saline in there. So the patients are never without the ability to remove that lens and then reapply that lens. It really helps, again, with that forefront thinking and not getting to a troubleshooting point with those patients. So as much as we can do for them to comply. Insertion removal is one of those things, repetition, 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 observing that to make sure they are properly doing it. The things that we see the most are patients not really using enough saline, not putting enough into that base curve or well of that lens, not overfilling it, especially if they have a reusable bottle and not a one dose usage saline. If they have a reusable bottle, they'll try to skimp on that amount that they put into that lens. They will do it, I'm telling you. So we need to make sure that it's about filling it properly and not getting any air bubbles. So if you're consistently getting air bubbles, it's definitely a technique, and probably 99% of air bubbles are technique. The other thing we see a lot of times is they're really just not, they're scared to use a little bit of force when putting that lens on. So are they pushing onto that cornea, pushing that lens to relieve it of that excess saline and get rid of the chance for bubbles? So it can be a fear of that, but they just have to know that if they're putting it on properly and straight on, that there's not going to be any adverse effects with that. And in removal, it's always near the edge. Now, this can be at 6 o'clock, this can be at 12 o'clock, that's your preference. And then a slight push in really, really helps to release that suction from the other end. So if I do it at 6 o'clock, I can release the lens from 12 o'clock. Or if I do it the exact opposite, just a little pressure in there will really help. So these are the most common things we see. I always recommend on removal just to hydrate, just to drop some saline on there. They can use their lower lid to manipulate the lens and get some exchange, and that lens will come out really, really easily. Another nice trick is when you're using the removal tool to hydrate that, and it will attach to the lens a lot easier. These are the most common things we see. And again, once we do this at the beginning, it'll take care of a lot of problems at the end. We see bubbles all the time, but we've got to know the difference between a bubble and if we're seeing touch. And I see this a lot in the beginner fitting process of not knowing what bearing or touch is, and then what an insertion bubble or a bubble, even a fit bubble, can be. And I'll tell you the way I distinguish it is this. You see how this lens here on the upper left-hand corner is really not having a distinct circle around it. It really has a faded in kind of fluorescein where it's fading out as we go further in that dark area, where this is completely distinct circle around it. That's the easiest way to tell between if I have touch or if it actually is a bubble that I'm seeing. So that makes it really easy. Again, 99% of bubbles are going to be insertion technique, user error. Slight touch, you'll see. You don't see that distinct ring around it. And then small bubbles. With small bubbles, if they're out of the optic zone, we don't really worry about them too much. They tend to dissipate as that lens settles down. If they're consistently getting small bubbles, it's probably, again, insertion. They could have changed their saline, so we don't want to use any aerosol saline, anything like that, or they're having a bubble as they're applying the lens already in the saline. So it's things to look for. We rarely see fit bubbles. They're usually on obviously highly challenged irregular corneas, but it does happen. It can happen. And then we just need to make our adjustments. So we go straight to our central zone and start troubleshooting from there. A nice thing that we've done with our new design and trying to get the practitioners and our consultants to follow the same kind of flow chart is we've made this decision tree that comes with our fitting set, and it makes it very simple to analyze what I'm going to do once I've got my goal. So our goal here is to get 200 to 400 microns upon insertion, right? 200 to 400 microns of clearance upon insertion. And then I can observe what I see and go down my decision tree to make my next step. So going back to knowing your design, I have to know if the central zone is two basics. I have too much clearance or I have too little clearance. So I have to create more clearance or take it away. And I have to know how I can do that. So by design, it can vary. There's going to be 3 ways that you can adjust that clearance level. You can do it through a base curve. So if I steepen my base curve, I can create more clearance in the lens. And that'll happen with any lens, just depending on the function of it after that. We can do it through a sag adjustment. So I'm not changing the actual base curve of the lens. I'm actually changing the sag, the central sag of the lens, and increasing it or lowering it accordingly. And it really doesn't have an effect on the base curve. So again, if I'm looking at an over refraction, it wouldn't have an effect on that. So you can make sag adjustments in some lenses that work independently and don't have to be done through a base curve change, but we can manipulate that sag. And that's the way our design works, the Atlantis design. And then another way is through the edge. So some designs, you can manipulate that sag and increase or decrease it by steepening or flattening the edge. So if you steepen the edge, you actually increase your central sag. Important to know what design you're using and what options you have and how they work when you're making changes. Now, when we're looking at the limbal zone, same thing. We have to have our goal, and then we have to be able to evaluate what we're seeing from that goal to make our changes into that limbal zone. And the limbal zone is really nice because most limbal zones and most designs work independently, meaning whenever I make a change in that limbal zone, it doesn't have anything to do with my central zone or my edge. So I can increase or decrease that limbal zone accordingly, depending on the problem. All right, and then I can make those changes to solve that problem. If I have too much clearance and I'm seeing something along the lines of fogging, so too much limbal clearance, we can get fogging. So we've left too much room there, and that's probably the number one thing we see is that fogging or haziness behind the lens because we've had too much clearance. Now it could be central clearance or it could be limbal clearance. So we have to search and destroy in that. If we see conjunctival prolapse, so we actually see the tissue bearing down so much, we're getting a suction inside the lens and we're getting that conj prolapse coming inside the lens. That could be caused by too much limbal clearance. We see this a lot in older patients. Obviously, they have a soft conj or bulbar where we're resting on that and moving that tissue around so much. So if I see this, the first thing I'm going to do is probably move my limbal clearance down. So I have the ability to move it up and down. You want about 100 microns of clearance. Now that can vary again by design and how much central clearance. If I'm not seeing any issues and I've got less than 100 microns of clearance, I'm fine with that. One of the other nice things that you can do, not only can you manipulate it up and down, with our design, we can manipulate the highest point of that limbal zone in or out. We don't have to get into that, but it is another function of that. So you can see if I have that limbal bearing, this absence of fluorescein around that limbus, I can just control that area and increase my zone where I have that bearing. Now, again, it's important to know what the design is. How wide is my limbal band and how much can I move it? How many microns can I increase it? In our case, you can increase it 300 microns. So I can move that limbal area up 300 microns or down 300 microns. And you can do that in a quadrant specific manner if needed. If you were not seeing this absence of fluorescein all the way around the lens, you could move it individually quadrant specific. All right, it's nice to know. So you need to know how wide that band is. If I do make a change in that limbal zone, I want to make sure that it's going to be over the area that's bearing here. So how wide is that and how much can I move that up or down? Again, most of them will work independently, so you really don't have to worry about it changing this central area or that edge. And you can see here, it may be difficult to see, but this is where we've increased just that limbal zone. We haven't touched that central zone, but just in that limbal area, see this nice area where all that fluorescein is? We've increased it there. We've exaggerated it just to show that you can increase just that zone. And then this is one of my favorite pictures ever. So we were doing our clinical evaluations when we first started out with our Atlantis design, and we had a patient in, and we put a lens on that patient, and we asked her if we could take some pictures, and then we took the lens off. All right, well, she was supposed to take the lens off. We then put the same exact lens on her, or she applied the same exact lens, and the only difference was we increased our limbal zone. So we increased just this zone on this patient. Well, she put the lens on and she was terribly uncomfortable. We asked if we could get her under the slit lamp and she obliged. And we took this picture. So if you look at right at the limbus, these air bubbles that have formed here, the patient never took the first lens off. So we had two lenses on her, one on top of the other, and the only difference was the lens on top had a deeper sag in the limbal zone, and that's why those bubbles are there. So we proved that our design was working. We just didn't feel like we wanted to prove it that way. Pretty interesting. All right, now going to the scleral zone again. What am I looking for? What are my goals? What am I seeing? And then how can I change it? So this decision tree is on our website, and Santiago gave you our website in the chat, so you can go on there and get any of this information. We'll also have the webinar up once it's complete. We'll do a little editing and then we'll put it up there also, so you can go back and look at these things. As we go through the edge is very, very important because of the settling process. We really don't know how much a lens is going to settle. It's unpredictable. We hear in studies from 50 microns of settling to 200 microns. In our design, we have an extremely flat edge, and the reason for that is because of the settling process. So we see from 50 to about 150. So we've got to know what we're seeing on the edge, and then we have to know where we're seeing it. And when I say where, I don't necessarily mean in the 360-degree range. We do want to check all four gazes, and we do want to check 360 degrees. But if I'm seeing something going on with the lens, if I'm seeing that blanching or impingement, I need to communicate again. If I'm talking to a consultant, what am I seeing and where am I seeing it? So in this picture in the bottom right-hand corner, you can see at the very edge, I've got that sealed off. I've got disruption of the vessels. You can see how white it is, even though I didn't do a close-up. So I know I want to lift that very edge up. It's a tight lens. In this OCT, you can see this, the back side of the lens, edge radius, and the front side of the lens, and it's settled into that tissue, and you even have the tissue coming up over the edge of the lens. Now, this is probably not going to, I'm not going to just flatten, right? I'm not going to flatten that edge in this case. I've got more going on here, and I need more evaluation, especially with the slit lamp. But back to this lens, I can just change that very edge. I can flatten it because I'm seeing it at the very edge. Now, if I were seeing this inside, more towards the limbal area, I would have to make a decision on if I still can change it through the edge or if I have to do it through my limbal zone. You must know your design. How wide is my edge? How much can I move it? If I saw an edge that looked good on the very edge, and maybe I see this whitening inside a millimeter or millimeter and a half, I might make a different change than I would if I'm trying to lift off this edge. I need to relieve that inner edge. So in that case, I would steepen the edge. So it's very important to know not just what's happening, but exactly where. If you say to a consultant that I'm seeing impingement or I've got blanching, and it's not really descriptive or it's not a picture, it can be difficult to make those changes. And again, they should guide you through that with the proper questioning. We see a lot of tight edges. We'll see good initial comfort with these tight edges, and then it will reduce the wearing time. So as that lens settles more and it tightens up and we're sealing off and disrupting those vessels, we will see that that lens is not very comfortable as the wearing time goes on throughout the day. One of the things you can do, or two of the things you can do, is just a simple spin test. So not only when you're doing the trial fitting initially, take your finger and literally try to spin that lens left or right to see if it moves. It should move pretty freely. But then again, on the follow-up, it could be very important to use that spin test, because the follow-up usually happens when you see a fully settled lens. When we do our initial fitting and it's out of the trial set, most of the time we're only giving 20 or 30 minutes to evaluate that lens. And for a lens to fully settle can take 4 or 5 hours. So on the follow-up, very important, you might want to try that spin test. A lot of practitioners will just wipe the front of that lens with some fluorescein, put some fluorescein on the front of the lens, and then see if they're getting any of that fluorescein at least under the edge, okay, under the edge, so it's not sealed off. And they may even do a little push-in test to see if that fluorescein will get under that lens and behind the lens. So there's a couple things that you can do for that. We mostly see tight edges. In our design, we mostly see tight edges. Going back to how flat we initially start with our lens, we really don't see, we see a little bit of edge lift, but it's not excessive edge lift. It's a nice starting edge lift upon insertion that dissipates as the lens settles. So I'm constantly going back to the patient and asking them about comfort. We want to know about their comfort. And if they have discomfort, where do they have discomfort? And then is it discomfort or awareness? If it's just an awareness, then I'm okay with that. And I'll ask them throughout the fitting process, is that awareness dissipating? All right, if I see edge lift, but I see that the patient's comfort is increasing as the fitting process goes on, I'm pretty sure that there's not going to be an awareness once that lens fully settles. So it's important to know between awareness and discomfort, and then you've got to specify where do they feel that? Where are they feeling it? Inferior, superior? So you take a good look at that and then make changes accordingly. Again, if this is on a follow-up visit and I'm looking at a fully settled lens, I'm going to make those changes. If we do see some of this lifting off, this edge lift, where you can see this is really drastic, and we're seeing that fogging, that tear film fogging, we know that we're letting debris get under and in behind that lens, and then it becomes stagnant and it's causing some of that. We also can see air bubbles at this point. We can see that we're so far off, it'll cause an air bubble on there. So again, going back to observing and knowing insertion removal process important, but is it because of the fit? It's a rare thing that we're going to see a bubble behind that lens that's been dispensed. You know, we usually take care of those problems on the forefront in the trial fitting process. We do not often see flexure. It's actually under 2% of the time where we're getting flexure. Going back to the decay of the materials and trying to keep your center thickness, so direct effect of center thickness to flexure. We try to keep our center thickness on the thin side for the very reason of we want to get oxygen to that cornea. But then you're in that place where if I go too thin, it could cause flexure with the blink. So the blink's coming down on this steep, big lens, and it's causing flexure. So we've got to be able to analyze that. The easiest way is over Ks, or you can do topography over the lens. You really shouldn't see much difference in your Ks or your topography Ks, sim Ks, or manual Ks. You know, you might see a half a diopter. It should be pretty spherical because of that nice lens. If it is over 3/4 of a diopter, then you may have some flexure. All right, so if you're seeing that, again, if it's the K's over it, not refraction cylinder. So in that case, what we'll do, we used to, and this is several years back, we would immediately thicken that lens up. We would say, okay, whatever thickness we're in, let's increase it by 0.10. So if I was in a 30 thick lens, I would increase it to a 40 thick lens. Well, now with studies and getting more information about lenses on eye, we've noticed that we can take care of a flexure problem just by moving to a toric haptic or a toric scleral zone. So the number one thing we'll try is go to a toric haptic or scleral zone, kind of take away that flexure, and we'll talk about the other problems that it solves with going to a toric scleral zone. Now, going back to the thickness of the lens, again, it's important to know what lens you're working with, what is the thickness in my fit set lenses, and then what is the thickness on my patient lenses. Because from a lab's perspective, when you make a lens, the lens thickness is determined by the power of the lens. A minus lens will be thinner than a plus lens. So the power of that lens determines your thickness. So it's important to know what that thickness is, not only in your fit set, which most of them are all equal. In our set, they're all 300 microns or 30 thick. But when you get the patient lenses, important to know what that thickness is also. Now moving to the toric, haptic, or the scleral toricity, very important that we use this more and more because of the advantages that we have with this. Not only, again, going back to that, reducing the flexure, it is improving the comfort. The alignment of that lens on the sclera helps with the comfort tremendously. We also know through clinicals and then our own data that we can improve the centration of the lens. So a lot of times we're seeing this residual astigmatism, and it's not really true residual astigmatism. It's because we are not looking at a centered lens. Some of these lenses ride inferior nasal, and if we can put a toric haptic or toric scleral zone and improve that centration, and we can improve comfort, and we can take away flexure, and we can take away if there is some of that fogging or haziness, well, why not do that? So in our new fit set, we have gone to a toric scleral zone in every lens, and we increase the amount of toricity as we go up in size. So remember, we have all these advantages, and they can solve a lot of these problems: comfort, centration, tier layer fogging, and then that residual cylinder. If we continue to have residual cylinder, because we are fitting more and more normal corneas and these high astigmats, we'll have a diopter and a half of residual cylinder, and then we can move to a front toric lens. The toric haptic will be our stability method for that front toric lens. So we'll use that haptic toricity to orient the lens and get a sense of stability and rotational stability. So when we have that residual astigmatism, we've got to make sure that it actually is residual astigmatism. Some of the causes, it's not one of those things where we go to it often because we're fitting mostly irregular corneas, which is corneal astigmatism, and we're correcting that with the lens. But when we see it, we use the toric haptics for a front surface toric. So when you're going to a front surface toric, some of the things that we should be looking at, you can achieve obviously the better vision. So anything above a 75 residual astigmatism, we are putting that front surface toric. We talked about lens flexure. So if we use a combination of that toric haptic and the front surface toric, you should be okay with that. All right, so it's things to think about on these before we go into that. I can tell you, when you go to a front surface toric, you're adding 2 more parameters to a lens. And every time you add a parameter to a lens, you increase the chance for an exchange, right? So now we've taken a spherical lens and we've created a toric periphery or haptic and a front surface toric. So we've added all these parameters. There's more chance of an exchange because there's more that we have to look at and more that we have to fit. So when we're looking at that, if you look at the front toric optics and you're using the stability of the toric haptic, it's an easy process to get your over refraction and then determine your axis because of the rotation on the front or on the toric or the toric haptic is what you're going to use. So we look at the steep axis and where that has rotated and the stability of that. And what I mean by stability of that, I'm going to look at the dots on the steep axis. So if I go to this lens, I have quadrants 2 and 4 as my steep axis. I'm going to observe that and where that steep axis has rotated to. And I want to make sure I have stability. So I want to make sure that I've let the lens settle and I can rotate that lens and it's going to rotate back to the same place. I've got to have that rotational stability, all right, in that toric haptic. So I know when I go to a front toric that I'm going to be stable and I've done my due diligence on my over refraction. So simple equation with your over refraction Obviously, you got to know your trial set. Again, know what my trial lens power is. You have your over-refraction and your axis. If my over-refraction axis is greater than the steep axis, I simply minus, and that'll give you your final axis. You can see here. So we added in the over-refraction to our -3. That gave us a -4 with the 2 diopters of residual at axis 100. And if it's less than, you're going to do another simple equation where you minus it from your over refraction, and then you do it from 180, giving you the 150. Two simple ways of doing it. You can also simply do LARS. So evaluate the amount of rotation or where your steep axis is, and then use LARS from there. Left add, right subtract from there with your over refraction cylinder to get your final axis on that. Very simple, very easy. The biggest point is make sure rotational stability has been done through the toric haptic. Some other things that we address that we hear, and again, it's patient. We've got to know, we've got to communicate with the patient. We've got an uncomfortable lens. All right, well, when is it uncomfortable? When are you putting the lens on? When are you taking the lens off? How long throughout the day? So am I seeing it, if I have comfort upon insertion, is it comfort that is coming later in the day? How long can you wear the lens? When do you see the discomfort? Are you feeling discomfort when you remove the lens? All these questions have to be known, so then you can make the change for the patient and for yourself. So it's going through the list of questions again. If I have a patient upon insertion that's feeling discomfort, then I know something's wrong there. Are they getting debris? Are they getting something under the edge? Do I have a problem with the lens or the edge or the fit? If it's not sustained comfort throughout the day, so if they're getting 3 or 4 hours and it's later in the day that they're feeling this, again, what is causing that problem with that comfort? So there's different levels of comfort, and it has to be known when they're feeling that comfort and where they're feeling that comfort. We know that a tight edge worsens throughout the day. All right, we know that that settling process will worsen throughout the day. We also know that if we are too close to the limbal area, and that's the sensitive stem cells, that could cause discomfort. So you've got to go through your checklist and know why they're having discomfort. We talk about corneal touch, and corneal lenses causing a lot of discomfort. You may see that in a scleral lens. And the prime example is a cone patient that's coming from a corneal lens and has been resting on that cornea for 3-4 years. So that lens has been laying on that cone and pressing down. We're essentially flattening that cornea. When we take that pressure off and we apply a scleral lens, and now that cornea starts to rebound, if we haven't had enough central clearance at the beginning of the fitting process, we may have corneal touch when we come for that, when the patient comes for that follow-up, or even 2-3 months later. There's not a real good determination of how long they wore a corneal lens to how long it takes for that cornea to rebound. It's different patient by patient. So we've got to make sure what we're seeing, if it's uncomfortable, that we're making the right changes through that. We've talked a lot about fogging, haziness. This can cause blurry vision. Again, we need to know, why are we having this vision? Why is it different than what we're used to? And we can find out through a slit lamp evaluation, and even through an OCT, we can see the buildup behind the lens in an OCT. So if you see that clearance and you see all this buildup, and they're not getting their best corrected visual acuity or what you did on the initial fit, then we know that we've got to make some changes. Do we reduce that central clearance? Is it because we have too much limbal clearance? And then I'll go back to the patient. If I've done both of those things, if I've looked at the fit and I know that I've reduced my central clearance, my limbal clearance is good, My edge looks great. The comfort's amazing. Now what do I do? I've got to look at hygiene. I've got to look at, is the patient using unpreserved saline? Are they rinsing the lens? Are they rinsing the conditioning solution off the lens before they apply the lens or before they put the saline in and apply the lens? So search and destroy. It's question after question after question. If we're seeing this blurry vision, it could be flexure. It could be the residual. So those are things that we're doing on the forefront in our fitting process to basically eliminate those on the follow-up. And then what I like to do a lot is remove the lens. Now let's check out the cornea. Now let's check out where the lens has been settling. Now let's see what we're getting with the vision. Those are keys to knowing. So observing the patient not only through INR, but even the cleaning regimen and the cleaning process. Are they cleaning it really well? Are their utensils clean? Can we cause some of that surface non-wetting because they have improper hygiene? If they're not taking care of the utensils and they're placing that lens on the utensil, well, that's just going to come off from the utensil to the lens and cause that central haze or fogginess. So it's up to us to look at it, ask the proper questions, and then observe. Observe the patient. When they are cleaning it, are they getting really deep into that base curve? Because we know these lenses are deep, and a lot of patients will not get into that. They're expensive. Patients are afraid of breaking them, so they'll do less in handling for fear of breaking that lens or ruining that lens. When we see these surface wetting or deposits, there's a lot of things. It could be material. It could be the patient. The compliance is a big thing that we see more often than not. So you go through that, and after your observations, then you can make changes. We talked about the material changes that you can make. The cleaning regimen could be another thing. Conditioning, are they properly conditioning it? Are they doing it the right amount of time? Some practitioners will even do an on-eye DMV, so they use it as a cleaner and wipe the front of that lens with that DMV. ProGent is great. I know with HydroPeg, we cannot use a ProGent, but ProGent is a great way of making sure that those deposits don't build up on that lens. And then HydroPeg. It is a problem solver. We do this through, it's about 25% of our lenses. We use the HydroPeg, which is the polyethylene glycol. It makes a super slick surface for that patient. So not only does it help with dry eye patients on the front surface, we know with dry eye patients behind the lens, we have all that hydration of tear and saline, but on the front of the lens, we make a super nice smooth surface for that patient because it's a dry atmosphere outside of that, on the front of that lens. We also use this for heavy depositors. So when we put that polyethylene glycol on there, creating that nice surface, it is deposit resistant. And it does help with that compliance, really. So if they aren't that great at cleaning the lens, if they do have the HydroPeg, they can go a lot longer with that without getting the deposit buildup they may get without having the HydroPeg on there. So options for that surface wetting and deposits. Again, we've got to look at it, know the information, and then make the changes from there. We see some obstructions, penguiculas, pterygiums. It's good to know what options you have with your design. So with our design, you have options in any design to make a lens smaller. So if you wanted to fit inside that obstruction, you could simply go to a smaller diameter and fit inside of it instead of laying on that obstruction. You can go larger. A lot of times with smaller, we're back to a corneal lens, which we really had been trying to avoid by fitting a scleral. If we go larger, you may have to go to a 17.0, 17.5 lens, or even larger than that. Some of the problems with larger lenses is application and removal. So the options that we give you is a cutout, or the option that we give you is a cutout around that obstruction. And this is very popular and very simple. We take a finished lens and simply cut out part of that lens which goes around the obstruction, and the patients can just rotate that lens into place. And you can see sometimes it's less exaggerated and sometimes more. You can do it on both sides of the lenses if you need to, but this is the easiest way we found. You can make a quadrant specific lens with a really, really steep edge and create more of a vault over it. It's just hard to determine. Sometimes if you're too far off, you get bubbles underneath there. And if you're too much on, you're still creating an uncomfortable lens. So the cutout is a nice option for those. So I will end this before we go to questions with, again, we want you to know that we're here for the patients. We are completely manufacturing. We're still doing our full day of manufacturing, even though for all of us, business is down. We're abiding by all guidelines that we need to in that. And we're actually looking at, when we're reopening, what guidelines are we going to follow and what testing are we going to have for that. So our turnaround time is still pretty consistent in that 24 to 48 hour turnaround time. Our consultants are all available. So they are customer service and consultation. They work remotely anyhow. So they are working from their homes and already quarantined. So that's a nice thing at this point. For the warranty policies, one of the things we've done, and it depends on the situations, but we've extended the warranties in some cases because we know that you may have ordered lenses, 30, 45 days ago, and the patients are not coming, or they may have canceled their appointment. So just contact us in any situation for us to extend that warranty. We want you to keep the lenses, and we want you to fit that patient and get that patient happy. So we're extending our warranty policies. You can contact us directly. It's a nice thing because you really don't have control of when you're going to see that patient again. We really don't know how this is all going to end up and when we're really going to get back to normal. So just contact us if you've used us. If you haven't used us, again, we're fully functioning, so you can. I know some labs have closed completely, so it is an option for you. And then the in-office fit and wet labs, the IOF and wet labs, are now obviously through webinar. So not only are we doing these educational seminars and webinars in groups like this, where we're just looking for subjects that practitioners want to learn about, but we also do them individually. So if you wanted to get your office or colleagues together for a specific lens type or lens fitting or whatever it may be in specialty contact lenses, we can individually set up one of those webinars for you, your staff, or you and your colleagues, or if you're part of a group. So we're always looking for those opportunities, and then we're always looking for information on what you would like to know, what you would like to learn about, what else can we provide for you to educate you if it is about our lab or our lenses, or any lenses for that matter. So thank you very much. We appreciate you joining us. I can take any questions, or you could type in any questions. I don't have any as of yet. Okay, we will end the session now. Oh, wait, I got a hand raised. You can, okay. Thank you very much. Please be safe to you and your family.